Okay, we are a bit late, and we move on to one of the more exciting section of this meeting, which is now related to the CAR-T experience. It's a great honor for me to get with me my great friend Franco Locatelli, who is in this moment probably one of the persons more involved as Italians in the world and in the Italian country to develop in this exciting new opportunity of therapy. And the first presentation will be from my colleague Anna Ferrara, triple negative B acute lymphoblastic leukemia. Anna, we are a bit late, and so try to save a bit of time. Thanks.
Good afternoon. I'm going to report our experience on triple negative B-cell acute lymphoblastic leukemia, mainly in adult patients. WHO BLL classification in 8 years added only 2 provisional entities, PH-like and AMP21. But if we consider research discoveries in the last few years, we have a very dynamic scenario that keep to increase and that reflect the heterogeneity of this disease. That is quite difficult to follow in every update. So we decided to do a widespread fusion meta-analysis. We screened about 6,000 fusion. So now we have a big database where each fusion is detailed by age and BLL subtype. Fusion were described in 31 different BLL genetic subgroups, and PH-like is the group with a higher fusion variability. So we have 2 sides of BLL identification and classification. The research side that is quite difficult to follow, and only a few institutions could apply to every patient. And on the other side, we have conventional diagnostic classification that could detect the most recurrent translocation. In adult patients that we follow in our institution, the 40% of patients could be classified with conventional methodologies, but pH negative without the 3 main recurrent translocation in adult patients here reported, and that we collectively called as a triple negative, represent about the 60% of patients, and that is the group where we are focused on. So CRLF2 is frequently altered in BLL adult patients, mainly in PH-like adult patients, that present in over 50% of cases alteration in this gene. Alterations that are caused by different mechanisms like fusion, mutation, and copy number gains, and that lead in the majority of cases to an overexpression of this gene. Recently has been reported that CRLF2 overexpression in adult patients is associated with a poor long-term outcome, so novel strategies are required to improve the survival. To do that, starting from the frequent event of CRLF2's overexpression, we cluster triple negative adult patients to find new markers for target therapies. Gene expression profiling were performed on 51 triple negative patients on 29 Philadelphia positive and 7 healthy donors. And triple negative were molecularly characterized using a variety of methodologies to detect variants, copy number, and fusion alterations. We developed a pipeline based on CRLF2 overexpression to cluster our gene expression data. And here I report the 10 genes that we use to stratify our patient. These are the impact of each genes on our clustering, and thanks to this pipeline, we could identify two subgroups, the group 1 and the group 2, that respectively represent almost the 77 and 23% of our triple negative BLL cohort. But if we consider that adult BLL triple negative are 61% of BLL patients, we could next say that the group 1 is the 47% of BLL and the group 2 is the 14%. Among the 10 genes, we identify the 3 major genes that are CRLF2, CTGF, and CD200. They increase their expression through groups, and also they are co-up-regulating in the group 2, so for this reason we call this group 3 C-up group. Regarding molecular features, we found that JAK2, CRLF2, and interleukin-7 receptor are frequently altered in the group 2, that Icaros and ABF1 deletion are significantly deleted in the group 2, and that RAS pathway genes are highly affected in the group 1. So this analysis shed light on a very heterogeneous scenario, especially in the group 1, suggesting that this group need to be better characterized. Regarding chimeras, we found a high rate of fusion that were not detected with conventional methodologies. And then we next compare the two subgroups gene expression profiling with pH positive 1. So as shown in this graph, the group 2 has a similar gene expression profiling to pH positive. So we know from literature that pH-like have a similar gene expression to pH positive 1. So we could hypothesize that in the group 2 could be contained many pH-like patients. This is also supported comparing our pipeline and using the 8 predictor genes for pH-like published in this important work. Notably, P53 is enriched in both subgroups, but with different deregulated genes. CHEK2 is upregulated in the group 1, and CDK6 is upregulated in the group 2, and for both proteins are available inhibitors that could be tested. So the identification of this new signature allowed us to identify new potential targets in the group 2. CD200 and CTGF are a direct target of monoclonal antibodies, and CRLF2 is an indirect target of CK2 inhibitors and also of drugs that act on JAK-STAT pathway. Given the similarity of gene expression of the group 2 and of the pH-positive group, we could hypothesize to test also tyrosine kinase inhibitors. We next developed a low-cost and quick cytofluorimetric analysis to detect the free C-up markers. And here in the case 3, I present a free C-up case that presents the co-expression of the free C-up genes. So in conclusion, we identify a new signature related to CRLF2 overexpression to classify triple-negative BLL patients based on 10 genes. The group 1 represents the 47% of BLL, and the group 2 represent the 14% and is characterized by the free CAP markers co-expression. The gene expression of the free CAP group is similar to Ph positive 1, and we could identify this patient at the presentation with the acetofluorimetric analysis. This new triple negative subclassification identifying novel potential therapeutical targets to test, as is our intention to develop in vitro studies to evaluate the efficacy of specific inhibitors. And in also our intention to apply our test and our analysis on a larger cohort. I would like to thank everybody who collaborate to our work, and thank you for your attention.
We get time for a rapid question, a burning question. Yes.
Very quick question, very nice work. I was wondering if you're planning to test CD200 antibodies, because this is one of your top targets, and there is monoclonal antibody, as you pointed out, blocking antibody that is available in preclinical models and potentially translated into clinic.
We are trying to have CD200 monoclonal antibodies, but we are not yet in the
Successful.
Yes.
And why did you use bosutinib?
And also we are trying to, we have 28 with CTGF companies, and we are now to test on some cell lines. So, yeah.
Why did you use bosutinib? I was just wondering, why did you use bosutinib in your studies? What was the rationale for bosutinib? You showed the last slide, you're testing bosutinib efficacy.
Yes, we tested bosutinib on primary cells. We started from bosutinib because we was available in our labs, and effectively we saw a more deeper effect on group 2 patient.
Do you know what kinase it's targeting, or is it?
This was a PH-LAC patient with JAK2 mutation and and one fusion transcript, new fusion transcript.
Thank you.
Okay, thanks a lot for this presentation.
So good afternoon to everybody, and let me start thanking Giovanni and all the organizers for having invited me to this meeting. It's really a great pleasure to be here today. This said, I am glad to introduce the next speaker, who is Dr. Gelli. His presentation is entitled Novel Therapeutic Strategies and Acute Leukemia Based on Synthetic Lethality.
Thank you. Good morning. I would like to thank the organizer for inviting me to have this presentation. And today I'm going to show you a few data on the opportunity to use novel synthetic lethality approaches to target acute lymphoblastic leukemia. Our cells are constantly damaged from intrinsic and extrinsic sources, but likely our cells develop different pathways in order to identify DNA damage on the structure and to promote an intercellular response which aims to activate the repair of DNA damage. So the overall mechanism involved in the recognition and repair of DNA damage is called DNA damage response pathways. And inside of this group, we find genes involved in the repair, cell cycle regulation, and induction of apoptosis. The main action of the DDR pathways is to slow down cell cycle in the presence of a damage to promote DNA repair, and in the case of an unfixable type of damage, to induce apoptosis. As you know, genomic instability is one of the cancer's hallmarks. Several groups have identified genetic alteration in main genes involved in the DNA damage response pathways. And for this reason, several targeted therapies have been developed in order to exploit the genomic instability. One of them is for sure the use of synthetic lethality approach. The definition of synthetic lethality is that arise when a combination of two deficiencies in the expression or functionality of two genes led to cell death, whereas the deficiency in only one of these does not. Today, two kinds of synthetic lethality have been identified. The first one is the genotypic specific synthetic lethality, or gene to drug, and the second one is the drug specific synthetic lethality, or drug to drug. As an example of gene specific synthetic lethality is the use of PARP1 inhibitor. PARP1 is a protein involving the recognition and repair of single-strand breaks. Single-strand breaks rise very frequently during cell cycle progression and during DNA replication. If we treat cells with a PARP1 inhibitor, we can generate a double-strand break more toxic starting from a single-strand breaks. Several researchers have shown that cancer cells that harbors mutation in the BRCA1 and BRCA2 genes that are generally defined as BRCA mutated or homologous recombination deficiency genes are particularly sensitive to PARP1 inhibitor. In acute lymphoblastic leukemia, mutation in PARP1 and PARP2 genes are quite rare, but it has been shown that particular subtype of acute lymphoblastic leukemia, like the CTF3 HLF translocated leukemias, are particularly sensitive to the inhibition of PARP1 due to the fact that this translocation, which involves different transcription factors, decrease the level of expression of microcephalin 1, which is a protein involved in DNA damage response pathways. As a result, we have also a downregulation in the expression of BRCA1 and BRCA2 genes, and so an attenuation of the homologous recombination activity. Regarding the drug-specific synthetic lethality, we actually can use this approach to exploit how cancer cell responds to DNA damage, or more generally to chemotherapy. So if we have a drug against an oncoprotein A, maybe the cancer cell may survive upregulating an alternative pathway, the pathway B. But if we know which are the pathways, the parallel pathways that cancer cell may activate in order to respond to a drug A, we can do a combination strategy and obtain the cell death. In our lab, we focused our studies on the study on cell cycle checkpoint regulation, and in particular on the kinase involved in the regulation of G2 and 2M phase. We published several papers evaluating the expression of this kinase in acute lymphoblastic leukemia cells, showing that there is an upregulation of kinase like ATR checkpoint 1, kinase checkpoint 1, and WEE1. And we showed that the inhibition of this kinase is effective against acute lymphoblastic leukemia, both in single agent and in combination strategy. We move on, and then we asked ourselves what was the best strategy to selectively kill cancer cells using the DNA damage response pathway. And we showed that if we inhibit WEE1 with a selective inhibitor, cancer cells or leukemia cells may survive overexpressing and overactivating checkpoint kinase 1 and 2. For this reason, we evaluated the efficacy of a combination strategy. We first of all started by evaluating the expression of these two kinases on primary acute lymphoblastic leukemia cells, showing that in both diagnosis and the RAPS, both kinases are positively co-expressed. Then we move on to treating our cell model and different cell lines using increasing concentration of two compounds inhibiting both checkpoint kinase 1 and WEE1, obtaining a synergistic effect in terms of reduction of cell viability and reduction of proliferation. Looking at the efficacy of the combination on primary leukemic cells, we perform clonogenic assays in order to identify the effect of the combination, showing that the combine of the two treatments nicely reduce the number of colonies. From a morphological point of view, we stained the cells harvested from the colonies, and we found that in the combination strategy, there was a significant reduction of primary leukemic cell, but I mean, again, I repeat, it's just from a morphological point of view. In the last few slides, I want to share with you some data about the potential role of ATR and ATM as synthetic lethality markers. Every time I presented my data on the inhibition of checkpoint kinase 1 or WEE1 on acute lymphoblastic leukemia, one of the most frequent questions from the audience was, how do you know that you are not creating a more resistant cell line due to the fact that you are actually inhibiting the mechanism of the cells to repair DNA damage? So to answer this question, I treated acute lymphoblastic leukemia cell line 6 for all over 1 year with increasing concentration of a selective CHEK1, CHEK2 inhibitor, obtaining a resistant cell line. As you can see from the cytogenetics, the parental cell line have a deletion on the long arm of chromosome 11, and by SNP array technology, we identified that in the heterogeneous deletion was the locus of ATM genes. Immunoblotting analysis confirmed that in the resistant cell line, the level of expression of both ATR and ATM and in the downstream pathways were significantly overexpressed. We then perform in vitro studies to evaluate the resistance to different DNA damaging agents, showing that the resistant cell line in which we have a higher expression of a protein like ATM and ITR, they were significantly less responsive to doxorubicin and methotrexate. And so we move on and we hypothesize that in the parental cell line, mostly of the cell were ATM in copy number loss, but there was a small clone with ATM in copy number neutral, so using the CHEK1, CHEK2 inhibitor, we selected the clones with the ATM in copy number neutral, and to assess if we can treat these cells with an ATR inhibitor to obtain a reduction of the cell viability, we perform these assays. As you see, the red one is the resistant cell line, and these are very preliminary data. Using an ATR inhibitor, we mostly don't have any effect in the reduction of cell viability, but in the parental cell line, in which we don't have the functionality of ATM, but only on the ATR, we have a reduction of the cell viability. We are about to start an European-funded project, which is called SynTherapy Project, whose overall aim is to identify a novel potential synthetic lethality strategy for both acute lymphoblastic and acute myeloid leukemias. We basically perform a molecular profile of primary leukemic cells treated ex vivo with different compounds normally approved for the treatment of relapsed refractory acute lymphoblastic leukemia, acute myeloid leukemia. And by using gene expression profile, mostly we will obtain a full change in the expression of the cancer cells that correspond to how cells respond to the agent, and then by using network propagation and protein-protein interaction network, we identify which DDR pathways are activated. And then we'll identify a list of potential inhibitor and validate it in vitro. So my conclusion are that although mutation in DDR genes are quite rare in acute lymphoblastic leukemia, the expression of these genes are frequently altered, and as I've shown you using very preliminary data, the expression of these genes like ATM and ITR may affect the responsiveness to DNA damaging agents, and the use of selective cell cycle checkpoint inhibitors are good candidate for as synthetic lethality based therapies. That's my slides. I would like to thank everybody who joined the project. And this is my concept of synthetic lethality, the Jenga. So we have to find the right brick that we have to remove to destroy the tower. That's it.
So many thanks for this nice presentation. There is time for a quick question with a brief answer. Okay, thank you so much.
It is a pleasure for me to introduce my co-moderator, Professor Locatelli, who will be presenting the childhood acute lymphoblastic leukemia, how to cure the very high-risk role of CAR-T. Thanks for coming.
So thank you so much, Giovanni, for the introduction, and once again, thank you to the organizer for inviting me. There is certainly no discussion that CAR T-cell has represented a sort of revolution in the field of treatment of lymphoid malignancies. And it is certainly not by chance that in the last issue of Science in 2013, this therapy was defined as the breakthrough of the year. And we have to admit, as Europeans, that this was a sort of pioneering story that was mainly conducted in the US institution, where different academic centers started to develop second generation of CAR T cells, differing either because of the co-stimulatory domain CD28 instead of 4-1BB, or according to the viral platform, retro or lentiviral platform, or according to a defined ratio between CD4 and CD8 cells, not to talk about the presence of a suicide gene. But if you look at this cartoon, you immediately realize that, for example, no one addressed the issue of combining a retroviral platform with 4-1BB, and thus the contribution of these two variables to the efficacy and persistence of CAR T-cell is still not completely defined. This say that despite the heterogeneity of the drug product, according to the characteristics that I mentioned before, they all resulted in a very high remission rate in a population of patients who had failed all the conventional therapies, including allogeneic stem cell transplantation. And in the internationally conducted study by Novartis, the so-called ELIANA study for the pediatric population and also young adult, you can see a remarkable probability of CR with or without complete hematological recovery associated with a very high MRD negativity. However, if you read critically the data for honesty, these exciting data are a little bit less enthusiastic if you reason in terms of intention to treat. And in view of this study, FDA first and then EMA approved the use of CAR T-cell for treating patients with a B-cell precursor, ALL. And I am particularly indebted to Stephen Group and the Novartis colleague who offered me the opportunity to present this data, which represent the updated analysis confirming that a relevant proportion of patients responding to CAR T-cells maintain remission over time. And remarkably, the CAR T-cell therapy is also effective in patients with very high-risk molecular or cytogenetic lesions, including hypodiploidy rather than MLL rearrangement, not to talk the BCR-ABL1 like BCP-ALL. And indeed, if you look at this table, you immediately realize that the probability of responding to CAR T-cell therapy is not influenced by the presence of poor race genetic lesions. And again, looking at the Kaplan-Meier estimate of overall survival, you can appreciate that also the high-risk molecular or cytogenetic patients have a very good outcome. CAR T-cell therapy, however, has also well-known limitations represented by the impossibility of generating CAR T-cells because either poor number or limited function of CAR T-cells, and by the CAR toxicity. And indeed, there are clearly the on-target of tumor toxicity represented by B-cell aplasia and a specific or non-antigen specific toxicity mainly accounted by the cytokine release syndrome and neurotoxicity. And again, if you look at the Iliana data, you see that even in pediatric patients, roughly half of children experience grade 3 to 4 CRS, and again, half of the patients were admitted in the ICU, requiring in around 25% of cases treatment with vasopressive agent or even intubation, 15% of cases. These findings clearly highlight that these therapies have an intrinsic toxicity, of course manageable in many patients, but to be promptly diagnosed and treated in experienced centers. And there is also a strict correlation between the neurotoxicity and CRS. Indeed, if you look at this cartoon, you see that the grade 3 neurological events occur mainly in patients who also had experienced grade 3 to 4 CRS. The other major limitation is represented by the tumor escape, being represented mainly by the emergence of apparently CD19 negative clones, apparently because they express on the leukemia cell surface isoform variant of CD19, which are not recognized by the monoclonal antibodies and of course by the CAR T cells. Other potential risks are related to the lineage switch, mainly in patients with MLR-rearranged leukemia or Ph-positive leukemia, and Marco Ruella reported also the case of an unlucky patient who developed leukemia with the transduction of the CAR, obscuring the possibility that the leukemia cells were recognized by the CAR. And if you want to compare CAR T cells with another form of immunotherapy, the BiTE or bispecific T-cell engager, the main difference in terms of leukemia recurrence is represented by the much more frequent proportion of patients developing CD19 negative clones when patients are treated with CAR T cells in comparison to those treated with BiTE. In Italy, and in particular in my institution, we decided to invest on academic programs on CAR T cells, and you can ask why do you want to invest on CAR T cells when commercial products are going to be available? And the answer are represented by, number one, the desire to have a drug product manufacturing process immediately available, because the commercial products have a sort of queue list because companies have to accommodate requests worldwide. The second reason was that of addressing question not of interest for company-driven trial, and also to address unmet medical needs. For example, we are running a trial on a third generation GD2 targeting CAR T cells for children with neuroblastoma. And also because we wanted to test whether in Italy there is the possibility of replicating the virtuous model win-win between academic institutions and companies. We were lucky enough to take advantage of a rather large GMP facility that was approved by the Italian regulatory agency in the middle of 2 years ago. And so we decided to address the question whether it is more important the co-stimulatory domain or the viral platform, using a retroviral platform, having for 1BB as co-stimulatory domain, and also including a safety switch represented by the inducible caspase-9 in case of side effects not controlled by pharmacological therapy. We conducted a very painful, I would say, preclinical work because it was very demanding to get the approval from the Italian regulatory agency. And we had to set up and to validate potency assay for the CAR T cell as well as for the suicide gene. We then move to the animal models, and we got a rather reassuring answer in the sense that in this model, when the animals were re-exposed to the leukemia challenge, the CAR T cell persisted over time and re-expanded. So we formally started a phase 1 to 2 clinical trial with the inclusion criteria very similar to those of the commercial products. Patients were given lymphodepleting therapy based on the use of fludarabine and cyclophosphamide, and we tested 3 different dose levels. We didn't record any dose-limiting toxicity in this very high-risk population of patients who had failed, in the majority of cases, allogeneic stem cell transplantation or other CD19 targeting immunotherapy, with also a very high percentage of blast at time of lymphodepletion. And we have been able to generate CAR T cells for all the patients that we enroll into the trial, with a very high transduction rate and viability, and the potency assay for both the CAR and the suicide gene was very reassuring. So we started the clinical treatment of patients, and as I mentioned before, we didn't record any life-threatening toxicity with the only exception of 1 patient, and the maximum tolerated dose, recommended dose, was 3 million per kg. CAR T cell expanded in patient peripheral blood, accounting in some patients for up to half of the circulating T cells. There was a correlation occurred in the dose level, the higher expansion being observed in patients receiving more cells, and this cell persisted over time. Of course, we also record that the cytokine storm reported by other, and there is a clear pharmacokinetics correlation between the expansion of CAR T cells and the elimination of CD19 blast. And when we look at the phenotype of the cells in peripheral blood, initially we found in the early phase after the infusion the presence of central memory and effector memory cells, then being substituted by terminally differentiated CAR T cells, and in the long term by even naive T lymphocytes. We recorded among children with BCP-ALL a complete response with MRD negativity in 12 out of the 14 patients treated, the percentage of responding patients being 86%, and the probability of overall survival that these children have at 1 year after the infusion is 71%, the majority of recurrence being observed during the first 4 months after the infusion. So in general, we can conclude that our approach is feasible and tolerable, but we are still working for trying to optimize the approach, preparing a bispecific or dual CAR construct targeting simultaneously CD19 and CD22, and also on NK cells for having a sort of off-the-shelf product immediately available. And I just show you this cartoon. Concetta will be a little bit more detailed in the afternoon, showing that CAR NK cells are equally effective than CAR T cells, both in vitro and in the animal model. But the production of pro-inflammatory cytokine, in particular interferon gamma, and tumor necrosis factor is much lower with CAR NK cells that you can imagine to use as a bridge for transplantation for those patients in immediate need to be treated with the CAR cell approach. Finally, I'd like to thank all the people working on this project, in particular the team of the Laboratory of Cell and Gene Therapy, and thank you for your attention.
Dear Franco, thanks a lot for this very nice presentation. There is time for question, particularly because the exciting data presented.
This is very exciting data. I was wondering if you're working on any CAR T for T-ALL, because that remains sort of unmet.
That's a very challenging task. Yes, we are working to prepare CAR T cells for T-cell ALL, but the real issue is that number one of the fratricide, number two of the T-cell lymphopenia that you have to consider in these patients. We can imagine to create a CAR construct to be treated for killing the T-ALL blast, but then this patient must be transplanted because otherwise you create a sort of a iatrogenic severe combined immune deficiency.
I know you are also working on solid tumor, since the SOHO, Italian SOHO, is a Society of Oncology and Hematology. So just a bit overview or a bit ideas how we can move to the solid tumor, which is more complicated.
So again, great question, and thank you for asking. Yes, we are working on neuroblastoma using a third generation CAR T cell where we combine CD28 and 4-1BB as co-stimulatory domain, again including a safety switch. We have already enrolled 20 patients into the trial, observing even a clearance of metastatic lesion, which was a sort of surprise. The other surprise was that the cytokine release syndrome was even worse in the context of neuroblastoma in comparison to the acute leukemia, probably because we treated very advanced disease patients. A limited portion of these patients still maintain a remission, but we have still to face the issue of a relapse after the initial response. The solid tumor poses major obstacle in terms of, how to say, not favorable, unfavorable, if you wish, milieu, immune suppressive, because of the many mechanisms that potentiating the immune response, the hypoxic environment, and also because of the issue of the penetration of CAR T cell in a solid mass. And for tackling this issue, we have decided to include in the CAR construct a metalloprotease to promote the penetration of CAR T cell in solid tumors. And We are willing to test this approach not only in pediatric solid tumor, but also in pancreatic and colorectal carcinoma.
Thanks a lot. So we are licensed to invite you next year to give a lecture on the CAR
I
T
would
cells.
be honored and
Okay.
delighted.
Thanks a lot. As mentioned, Concetta Quintarelli is now in Milan because he get awarded. He's awarded by a national level, so he comes in the afternoon. So we move on the next talk, which is by Professor Jabour. And the Professor Jabour is talking about the PH, acute lymphoblastic leukemia, how we can optimize treatment for all the patients.
Thank you very much for inviting me. Giovanni, it has been a pleasure working with you and being here. It has been 2 great days, and I hope I can come back again. So my talk is on PH-positive ALL, how we can optimize treatment for our patients. So the success in ALL resides into the fact that we have monoclonal antibodies and tyrosine kinase inhibitors. And of course, with the blinatumomab and anituzumab and moving them to the front line in combination with TKIs, we can further improve the outcome of these patients. Traditionally, in the old days, we saw transplant is the only way to improve the outcome of these patients. You get transplant, you have a donor, and then you have an outcome of 30-40% survival rate. Well, after transplant, patient may wish they never received the transplant, but that's a different story. Then we had the TKIs, and at MD Anderson, we combined them with the hyper-CVAD regimen. We had the hyper-CVAD imatinib first, and dasatinib and ponatinib. As you can see here, we did not improve the outcome with imatinib and neither dasatinib with a 40-45% survival rate. Then we had ponatinib, when added to the hyper-CVAD regimen, we have a 5-year survival of 70%. So, well, you say, I don't want to go for chemotherapy, and here I'm quoting my friend Sabina with work in Italy, where we're going to go for steroid and dasatinib, and you have a CMR, you do great. If you don't have a CMR, then you should go for transplant with more intensification. Of course, everybody goes into CR, but as Christina mentioned this morning, that is not enough because only 20% did achieve a CMR. And those who achieve a CMR have a better long-term outcome based on a multivariate model already performed. The French and the European, with Philippe Rousseau, essentially had a similar approach for patients who are unfit for intensive chemotherapy, 70 years old, median age, and then these patients had low-dose chemotherapy plus dasatinib, similar CMR rate, 24%, survival is around 35%. Interestingly, a lot of relapses driven by T315I. They reported at the baseline some mutations with 315I, although we could not confirm these findings. That being said, still resistance is being driven by 359 mutation and by the lack of achievement of a CMR. So here the mutations encountered, 75% having acquired the 359 mutations. So how we can improve the outcome? Well, first of all, we need to improve the CMR rate. Second, we need to prevent the emergence of a clone with 315I, and therefore we designed the hyper-CVAD in Houston, 8 cycles of chemotherapy. Ponatinib was given at 45, and further reduction to 30 milligram from cycle 2 and to 15 milligram once the CMR is achieved. And then we did provide 12 intrathecal chemotherapy. Now, at any time, if you have a donor, you go for transplantations. So we have a high CMR rate, so everybody's good to CR, but the CMR rate was 4.5 log reduction, is around 84%. And then we have 0 early deaths. So the hyper-CVAD was well tolerated early on, the first 2 cycles of induction therapy. With a median follow-up of 43 months, our 5-year survival is 73%. And of course, we lost patients from toxicities. We had 2 deaths, unfortunately. And then we had only 3 relapses, but none of them was driven by 359 mutation on ponatinib. Then, as we wrote the protocol at the beginning, if you have a donor, you go for transplant. 18 patients had a transplant performed with a median of 6 months. We perform a landmark analysis, and as you can see, those who did not have a transplant had a better outcome, where the survival at 3 years is 90%. Now, in all fairness, some who had a transplant had minimal disease, or half of them did not have any disease at all. Therefore, transplant will not be needed, and in our practice today, we don't get patients to transplant if they have pH positive and responding. The question about intrathecal, at the beginning, we used to give 8 intrathecal chemotherapy, but then with patients surviving and having a long-term cure, we did see what we called isolated CNS relapses. So we changed our protocol to implement 12 intrathecal, and by doing so, we don't have anymore the CNS relapses. Although most of these patients were on hyper-CVAD ponatinib, not the previous TKIs. Comparing to other TKIs in what we call propensity score matching to dasatinib in a previous trial done in Houston, there was a significant improvement in favor of ponatinib with a higher CMR rate and better long-term outcome. So Dr. Martinelli led the study in Italy with ponatinib as a single agent in patients who are unfit for chemotherapy, with the dose being given 45 milligrams per day. He reported a CMR rate of 40% on a single agent drug. The estimated 2-year survival 60%, and then we still have some safety concern with ponatinib at 45 milligrams per day, and therefore in our protocols in Houston today, we do not use the 45 milligram dose. Therefore, 2 approaches used to be the intensive chemotherapy of MD Anderson plus ponatinib, high CMR rate, less transplant, and a survival of 70 to 80%, or go for low intensity approach and rely heavily on transplantation. With the TKI used dasatinib or imatinib, we did not induce a high CMR rate, and therefore we rely heavily on transplantations. In the USA today, the NCCN guidelines recommend hyper-CVAD and ponatinib as one of the options for young fit patients for induction and then maintenance as well. So then we move to the new era of new drugs, blinatumomab and inotuzumab, approved today for refractory relapse ALL, Ph negative and Ph positive, with good efficacy in Ph positive for blina around 36%, I know a little bit higher, 66%, although survival is identical. Then what can say, well, why do I need intensive chemotherapy anymore? Let's go to a combination of a blina and TKI. And again, here the work that Sabina presented at the EHA in Amsterdam in June this year, where patients, all comers, median age 54, received a sequential approach of dasatinib for 3 months, followed by blina 2 cycles. And the primary endpoint was the rate of molecular response after 2 cycles of blina. And then after that, you can go for further consolidation with the blina, transplantation, or whatever you want. Great results so far. The molecular response rate at the 2 cycles, 54%, undetectable being 29%. In a report or in a presentation of Dr. Chiaretti was patients who had steroid did have an increase of the BCR-ABL transcript, and 4 of them acquired T359 mutation, although they responded well to blinatumomab. With a short follow-up, the outcome is great. In Houston, we use different approach. We said when it starts from the beginning with the blinatumomab, we don't wait for 3 months of treatment, and then we use the ponatinib in combination with the blinatumomab. We've treated 20 patients of protocol first, and in a relapsed refractory setting, we reported high response rate, higher in MRD positivity, and then we open this protocol today for patients who are unfit, 60 years and older, or relapsed refractory. And we give ponatinib for high count, just to cytoreduce, and then blina, once the count is below 5,000. And then we give ponatinib continuously at 30 milligrams and reduce to 15 once the CMR is achieved. And we give up to 5 courses of blinatumomab, intrathecal 12 to be given, and then ponatinib at least for 5 years at 50 milligrams per day. Here an update of the study. We have 12 patients treated. What you see in pink are the frontline patients who are unfit for chemotherapy. The square are CMRs. So 4 out of 6 achieve the CMR already, undetectable disease. And then the triangle in yellow is an MMR. So you have 5 out of 6 already responding. And then witches give us around 80% CMR rate without chemotherapy at all. So this is our ongoing study at MD Anderson today. One could say, well, you're not giving chemotherapy at all. Is there any room for chemotherapy? I will come back to that. But before I conclude, you know, when we give ponatinib, there was a concern about vascular events encountered on a drug. We look at the patient who received ponatinib in our trial, and 46% had at least one risk factor for vascular events, and smoking being 41%. I expect to be higher in Italy, but hopefully you're not smoking anymore. Good. When we look at the outcome by smoking and non-smoking, the non-smokers had a survival of almost 100%. And then people may say, well, are they having vascular events because they smoke or they have COPD, they die in CR? and we look at the resistance rate, smokers do induce resistance to TKI. So therefore, you have high rate of death, NCR from toxicities, and resistance. We're exploring right now with our colleagues in Houston the mechanism of resistance to TKI with the pharmacogenomics, the epigenetic differentiations that is ongoing right now. Unlike pH positive, pH negative ALL, smoking does not affect the outcome. So it's really through the resistance to TKI and not through other mechanisms. This is our current regimen today with the high-perceived ponatinib. We said for younger people, we want to use some form of chemotherapy, but not the high-perceived anymore, and we shorten it to only 4 courses, followed by blina, and then, of course, ponatinib 30 milligram and 15, and we introduce blina as part of the maintenance regimen. Transplant, no transplant, we perform a landmark analysis, CMR at 3 months, predict for the best long-term outcome. Those are the CMR at 3 months, have a survival at 4 years of 80%. Of course, it's not safe haven yet because CMR patients, some of them are relapsing, and we're trying to identify the reason of these relapses. Then we look at a patient who had a CMR and look at the survival, whether they had a transplant or not. The survival at 5 years is 74%, and transplant does not add anything. What matters for the outcome is ponatinib. If you have ponatinib given, you have less relapses and less 315I, of course, clones driven. 315, so ponatinib is the best TKI that we give today. So our algorithm today for transplant, if you have an MRD negativity, we don't go for transplant, chemotherapy TKI or blina TKI. If you are MRD positive, but you have 3 log reductions, what we call MMR positive, then blina or INO and TKI, no transplant. Transplant is only reserved for the group of patients who don't achieve an MMR or 3 log reduction. They will give them blina trial and then transplant and maintenance with TKI post-transplantations. Moving beyond that, Dr. Andrew and Carter did explore the role of venetoclax in Philadelphia positive disease, and we're opening a trial with venetoclax and ponatinib plus steroid for relapsed refractory population. We have 2 patients enrolled so far. So then the question is, I'm concluding with my last slide, do we transplant always in pH positive ALL? The answer is no, never. I won't say that, but I will say at least do a group of patients, a big group of patients who can be cured without transplantation. Today, 3 months CMR is relevant. I think ponatinib is the best TKI, and we have an ongoing randomized trial, and the Italians are part of it as well. Do we need intensive chemotherapy? The answer is not. I don't think so. Low-dose chemotherapy or eventually like APL cure these patients with TKI and blina. The work is done in Italy. In Houston, we use blina and ponatinib. Thank you very much for your attention. Happy to take questions.
Excellent presentation. Opening for a few questions, burning question.
Even not burning. BTK.
Obesity.
Obesity. You know, when we did ponatinib for obesity in CML, we did not see a difference in outcome. In ALL, we did not see a difference in outcome. However, the numbers are too small to draw like a significant conclusion.
You mentioned that the reduction of ponatinib to 15 milligrams in mostly of the program that you are ongoing, starting from 30 and moving to 15. Is this because you are combining or because you believe that the 15 milligrams will be enough? Because in our short experience, we see that sometimes 15 milligrams, even if you interrupted or you reduce very quickly to the 15, which is safe, of course, or you could be safer, sometimes getting a bit recurrence of 0.0001 transcript, which is nothing from a clinical point of view, but is...
in all honesty, we never treated somebody with single agent, and we did not use steroid and ponatinib. So, of course, with a combination, it was comfortable to reduce the dose of ponatinib and maintain them. Now, in patients who had a CMR and finished the treatment at 50 milligram for 4 or 5 years, they keep suppressing their disease without the need for dose escalation.
But you believe that 30 milligrams will be a problem?
Yes.
Okay. Thanks a lot.
Thank you very much.
If you would like to stay with me, since Professor, to moderate the next speaker, which is our friend, and we'll finish this section regarding the experience of pH positive treatment pH. Sorry, I lose my eyes.
So the present and the future of GMMA trials in ALL.
Thanks, Sabina, to come.
Thank you to Giovanni, thank you to the organizers. So just to move on what is the current role of clinical trials in Italy, in particular the GMMA trials. I will subdivide my presentation in what we are doing for Philadelphia positive ALL, also to stay in contact with Elias, and then we will also talk about Philadelphia negative ALL. As for Philadelphia positive ALL, as Elias already mentioned, we just close to enrollment and the data were presented at the latest AHA, the ALBA trial, also called 2116. Just to drive you briefly through the scheme of the trials, we use a completely chemo-free approach in which patients receive a first phase. Come si usa il pointer? Okay. No. Il verde grande. The patients received, no. Quale green? Okay, now I'm here. So patients receive a first 7 days of steroid-free phase, also to see if patients were in fact Philadelphia positive. They went forward with a chemo-free induction consisting of dasatinib for 85 days together with steroids that were tapered throughout the treatment. By day 85, patients were evaluated for molecular response, and regardless of molecular response, all patients received blinatumomab at the flat dose of 28 micrograms for at least 2 cycles. And the number of cycles could be up to 5 cycles. All patients throughout the treatment of blinatumomab received also dasatinib. The only patients in which dasatinib was not given were the not existing cases in which it was not achieved a morphological CR. The primary endpoint of the study was represented the evaluation of molecular response at the end of cycle 2. And afterwards, patients could receive a post-consolidation treatment that was free to the clinical choice. Throughout the treatment, also in light of what Elias already said about CNS prophylaxis, patients received CNS prophylaxis. 5 lumbar punctures were given during the induction treatment and the rest throughout the treatment. Just to make a long story short, Elias already alluded to, by day 85, which was the end of induction, 19% of patients received either a complete molecular response or a positive non-quantifiable disease. At the primary endpoint, that was post-cycle 2, 56% of patients with this chemo-free approach attained a molecular remission. And it is interesting to notice, it is interesting to notice that if you look at cycle 3 and cycle 4 and so on, the number of molecular responders increased throughout time. And this was slightly unexpected because from what we knew from the literature, the best response with blinatumomab could be achieved after the second cycle. So probably in chemo-naive and obviously in in the frontline setting, blinatumomab could be effective also continuously. Regarding overall survival and disease-free survival, though the follow-up is short and we are updating the follow-up for the ASH meeting, median follow-up 10 months, the results are extremely good. Overall survival, more than 94%. Disease-free survival, 87%. There were 5 relapses, 3 of them were extramedullary. In particular, although the CNS prophylaxis was carried out correctly, 2 were at the CNS level. We also performed a copy number aberration analysis for all the patients that were enrolled. And just to make a long story short, what we noticed, and then unfortunately we already knew these results, but we hope that the blinatumomab could improve this setting. The patients who are at higher risk of relapse and also of acquired mutation are represented by the cases who have not only Icarus, but Icarus plus deletion, meaning also CDKN2A deletion and PAX5 deletions. It is also interesting to highlight that among Icarus Plus, 4 patients acquired a T315I mutation, thus indicating that probably the 2 events somehow collaborate together to induce a relapse. So the results with this trial are definitely good, are very promising. The follow-up is short and we are well aware of this, but indeed we need to improve, at least for the patients who do not achieve a complete molecular response. So in the next trial that we are trying to design, definitely we want to increase the rate of CMR by probably by changing the TKI from dasatinib to ponatinib. We want to try to refine better molecular response, molecular minimal residual disease monitoring by using different techniques, not only BCR-ABL, but also immunoglobulin T-cell receptor gene, by using different techniques, quantitative PCR and also digital PCR. And one point that is very important, and we have been heard about this point several times, is to try to stratify better patients. So we want to understand the biology of these cases by using copy number aberration, the so-called Icarus Plus, the occurrence of mutation, and both minimal residual disease, mutation and copy number aberration will be used for better stratifying patients in terms of transplant allocation. So we are trying to write the protocol. There are already drafts ongoing, and we hope soon to complete the work. Regarding Philadelphia negative ALL, I also used the past because Christina already mentioned this trial, but just let me go back 1 second. The GMMLR 1913 trial, which was a trial that is the natural extension of the NILG 1007 trial, in which patients received an MRD-driven and pediatric-inspired chemotherapy regimen. In this trial, just to make some important point, patients were enrolled up to the age of 65 years. There were some dose reduction, mostly for methotrexate and asparaginase, up to the age of from the age of 55. The protocol was extended to whole Italy, and overall 204 patients were treated. We are waiting for the final analysis of this trial that will be carried out in October, thus in few days. But just let me show you some results which for me are quite interesting, considering also the age of patients that were enrolled. Overall survival and disease-free survival are extremely good at 24 months, 72.7% and 66% respectively. And even more interestingly, Marina already mentioned this aspect. If we look at the overall survival of T-lineage ALL patients, 83%, which is really a success. We already learned from the French that these patients really respond very nicely nowadays. The other important point, and I really like to stress it, is the overall survival according to age. It's rather obvious that younger patients do better than older patients. This is, as we say in Italy, Catalano. But if we look with an MRD and a pediatric-based regimen, the overall survival of patients aged over 55 years is 66%. So the results are very good. So probably we smoke, Elias, but still we have some advantages in lifestyle. So, as an obvious consequence of the GMMA 1913 trials, as already Christina mentioned, we generated the next trial, which is represented by the 2317 trial, in which obviously we included to the very same backbone as I showed you before, also blinatumomab. Blinatumomab is given at 2 levels. The first one is immediately after the first high dose of chemotherapy, and the primary endpoint of the study is represented really by this point, just to understand how much blina can increase the percentage of MRD negative patients. And just let me remind you that blinatumomab is given regardless of MRD status. So even if the patient is already MRD negative, will receive blinatumomab in this trial. And there will be another consolidation cycle of blinatumomab later after time point 4. I cannot really comment on this trial because the trial is ongoing. The sample size foreseen is of 149 patients, and we are almost at half of the recruitment. The other story, we already mentioned it several times, is represented by the so-called PH-like patients. PH-like patients have been defined in different ways. I would say that the presenter has his own way to define these cases. We published last year in British Journal of Hematology the so-called BCR-ABL-like predictor, in which by using 10 genes evaluated by quantitative PCR, we create a score through which we can define a patient's either BCR-ABL-like or non-BCR-ABL-like. So this BCR-ABL-like predictor is now currently performed in all the cases that are enrolled in GEMEMA trials. Obviously, they be negative for molecular aberration. And as you can see in the 1913 trial, the rate of patients who were refractory to induction treatment were much higher in the BCR-ABL-like, almost 26%. MRD positivity was much higher in BCR-ABL-like patients, and this obviously translates in different event-free and disease-free survival rates. So in order to overcome these, we are designing and we are trying to finalize this trial that has been already approved by Insight, in which all patients who have a diagnosis of B lineage ALL will undergo first, obviously, conventional molecular screening. If they are negative for major molecular aberration, they will undergo the BCR-ABL-like predictor. And if they result to be BCR-ABL-like, they will start treatment with ponatinib at different dosage together with therapy. The first 5 patients, this will be a run-in phase. The first 5 patients, for safety reason, will receive 15 microgram of ponatinib. If there won't be safety concern, the remaining patients will receive 30 milligrams of ponatinib. Just briefly, some points that were asked in other occasions. These patients will receive, obviously, chemotherapy, but for safety reason, we will omit asparaginase, and we hope that this will be a good move, but we obviously have to consider also concerns reason. And in this trial, patient will be allocated to transplant as soon as possible. We foresee to enroll 32 patients, also considering the incidence of these subgroups, and the primary endpoint will be represented by the evaluation of complete hematologic remissions as well as MRD negativity. Other endpoints obviously will be represented by survival rates as well as safety concern. The protocol is, as I was saying, being finalized, but meanwhile we were able to treat patients with ponatinib, at least as a compassionate use. And I just want to share with you this case, and I want to thank first of all the hospital of Novara, in particular Monia Lunghi, who really shared the data with me. Monia had this patient, 33 years old male. At the onset he was with hyperleukocytosis. He performed a diagnostic workup, a common BALL, cytogenetics were normal, the molecular screening was normal for major molecular aberration, but he underwent also a BCR-ABL-like predictor, as all the patients enrolled in the 2317, and he proved positive. We also performed in these patients RNA sequencing, and it turned out to be positive for a BCR-JAK2 mutation. This is the story, the clinical story. January enrolled in the trial. He is not in CR at the end of cycle 1. He achieves a morphological CR at the end of cycle 2, but he was still MRD positive. by protocol guidelines, he received high-dose methotrexate and RAC, and is still MRD positive. He receives blinatumomab as per protocol guidelines, but he had to interrupt blinatumomab treatment because he had a severe CRS. After a few days from the interaction, the patient go back to the center with more than 10,000 white blood count and a full-blown relapse. At this point, we were contacted. The patient started salvage treatment, to which he is refractory. During the HA in Amsterdam, in fact, we rediscussed the case, also with Insight. We tried to receive ponatinib as compassionate use, and while waiting ponatinib, the patients received 1 cycle of inotuzumab. At the end of the first cycle of blinatumomab, he still had 2% of blast. Therefore, starts ponatinib by the full dose of 45 milligrams per day. End of July, the patient is in complete molecular remission and obviously in CR, continues ponatinib. End of August, the patient is transplanted and is in CCR. We are trying to, so we should receive in a few days the evaluation post-transplant. However, the patient is in CCR. And I think this case is important for 2 things. First of all, because ponatinib works. We had some in vitro data, but showing it in the patient is very important. And the second important point is represented by the fact that this patient had a JAK2 rearrangement. So while it was quite expected that ponatinib could work in able class rearrangements, on JAK2, we already know the story of ruxolitinib can be always difficult, but this is really the proof that this concept can work. And with this, I would like to thank you for the attention and all the persons that are really working on this project. Thank you.
Any question? Steven, let me ask you a question. In your protocols, blina is introduced kind of 3 or 4 months for the Philadelphia negative. Why not adding blina earlier, after 2 cycles, or early on than waiting for later?
Because somehow we wanted to be consistent also in terms of comparing historical data. So we wanted to keep this TP2 and see what is the advantage of giving blinatumomab.
Well, here they're concerned because those with a high-risk disease, they may progress before they get to blina. If you have somebody with 411 or Philadelphia-like eventually, where they get TKIs, they may progress before getting blina. Won't be nicer to get the blina earlier than waiting for like 3-4 months?
Yes, you are right, but in that case, I mean, there will be off protocol for sure. And somehow it was really, I totally agree with you because we discussed it a lot. But it was really just to try to be somehow consistent with ourselves.
Okay, thanks.
Marina.
Question?
I have a question about your patient that you showed. You showed that after inotuzumab, actually, he did achieve a remission, right? But then
2% of blast, and
right.
we didn't do MRD because obviously
Right.
you still had blast.
So it sounds
So
like he did respond to and
it
then you
looks like.
consolidated with.
It looks like.
And can you hypothesize what is the target for ponatinib in JAK2 rearranged pH? Like,
I think that ponatinib being a pan-TKI could work anyhow. So we showed it in the previous paper. We did some primary, some experiments in vitro on primary cells, and some of these patients that were treated were positive for JAK2 rearrangements. But obviously, this was a reason I was really happy of seeing these results because one thing is in vitro, one other thing is on the patient.
great, thank you.
Okay, thanks. Stay with us just a second because as the first time of the SOHO meeting in Italy, we would like to guest our female speaker with a floral guest gift, and so I would like to call on the top Anna Ferrari, Marina Konopleva, Dottoressa Nanni, Masini, Papaianidis, Zini, Chiaretti, Terragna, Tosi, Simonetti, Iacobucci, Romano, Martelli, Ferraioli, Quintarelli, and Zamani. Thanks for coming. Un po' in mezzo. So, as an Italian style, for the first time the SOHO, and thanks. Okay, thanks. Okay, prego.
Grazie.
Prego. Prego. Se venite su voi. Ok.
Veramente galante.
Spostatevi là che facciamo la foto, via. Elena, fa un passettino in là che così entrano tutti dentro nella... Ok. No, no, this time. Next time. And this is for Maria. Where is Maria? Is there? Could you call Silvia? Silvia, could you call Maria? Okay.
So we need to frame it, take it to SOHO Houston so they can use it.
We have to stay out. Okay, Maria, please come. Come with us. Okay. Half an hour for the dinner, and then for the lunch, sorry, and then we come back in a short time. We will restart soon and 2:15, but we can probably start at 2 o'clock. Thanks a lot.